Hi, I'm Dr. Jessica Knight-Perry, Assistant Professor of Pediatrics here at Children's Hospital Colorado. I work in the Center for Cancer and Blood Disorders, and I'm a member of the Blood and Marrow Transplant and Cellular Therapeutics team. Our team of experts care for children and young adults with a wide range of both malignant and non-malignant conditions. Today, I will be providing a brief overview of our non-malignant transplant program, and more specifically, the hematologic conditions we treat. To start, how does transplant work? We know that hematopoietic stem cells in the bone marrow give rise to leukocytes, erythrocytes, and platelets. Therefore, absence or dysfunction in any or all of these three cell lines can theoretically be corrected with transplantation of healthy stem cells. In the conditions I will be discussing today, these stem cells are allogeneic, meaning they are derived from the bone marrow, umbilical cord blood, or mobilized peripheral blood of a donor. This donor is selected using HLA typing and can be related or unrelated to the recipient. Prior to infusion of donor cells, patients receive a conditioning regimen to suppress the recipient's immune system and to ablate their bone marrow. Current non-malignant conditioning regimens tend to be less intensive when compared to the regimens needed to cure malignancy. This reduction in toxicity, in addition to improvements in supportive care, has made transplant safer for patients with non-malignant disease, and in turn has expanded our transplant-eligible population. Allogeneic transplant is now part of standard of care therapy for a variety of non-malignant disorders, including immunodeficiencies, inborn errors of metabolism, histiocytic disorders, hemoglobinopathies, and bone marrow failure syndromes, all of which we treat here at Children's Hospital Colorado. Over the last 3 years, we have done on average 20 non-malignant transplants per year, which equates to roughly 30% of all transplants performed. In that time frame, we have transplanted a total of 34 patients with hematologic conditions, 21 patients with bone marrow failure syndromes, and 13 with hemoglobinopathies. Hemoglobinopathies, including sickle cell disease and beta thalassemia major, cause significant morbidity and mortality. There are approximately 100,000 individuals with sickle cell disease and 1,000 with thalassemia in the United States, with millions more worldwide. Sickle cell disease and thalassemia are inherited disorders with genetic mutations resulting in abnormal hemoglobin, and currently, hematopoietic stem cell transplantation is the only proven cure for both. In sickle cell disease, HLA-matched sibling donor transplant is well established, with survival greater than 90% in modern cohorts. Therefore, transplant should be considered in all symptomatic patients who have this option in childhood when we know outcomes are best. Of course, the final decision to proceed with transplant should be individualized and involve a discussion amongst the patient, family, hematologist, and transplant physician. Unfortunately, a significant percentage of patients will not have a matched sibling donor. In general, transplant for these patients should be reserved for those with severe disease and should be done on a clinical trial if at all possible. For thalassemia, transplant outcomes correlate with the Pissarro classification, a prognostic score that estimates the degree or extent of iron overload and stratifies patients into risk groups 1 through 3, with group 1 having the highest thalassemia-free survival and lowest treatment-related mortality. Therefore, adequate chelation therapy pre-transplant is critical in this population, as is early transplantation should there be an appropriate donor. Similar to the sickle cell population, overall survival is greater than 85 to 90% in low-risk patients who have a matched sibling donor. Efforts to improve outcomes with alternative donor sources, either matched unrelated or related haploidentical, is ongoing. As with other inherited disorders, gene therapy trials are underway in both the United States and Europe for the hemoglobinopathies, and in general, the results to date have been promising. However, the safety and engraftment durability of the genetically modified stem cells still needs to be fully established before becoming part of the standard of care for this patient population. Now on to the bone marrow failure syndromes. These disorders can be acquired or inherited. The most common of the syndromes is severe aplastic anemia. It is, however, still a rare disease with an estimated incidence of 2 cases per million in the United States and Europe. It has a biphasic distribution with peaks in adolescents and again in older adults. The majority of cases are acquired and thought to be the result of autoimmune destruction of hematopoietic stem cells. For patients with a matched sibling donor, the standard upfront therapy is a bone marrow transplant, with survival greater than 95%. However, for those without a matched sibling donor, immunosuppressive therapy is given first. Up to 70 to 80% of patients will respond to this therapy. However, approximately 30% will relapse and 20% will develop clonal hematopoiesis. Patients with either relapse or clonal disease are then considered for transplant. Improved strategies and outcomes for unrelated donor transplant in patients with severe aplastic anemia has led clinicians to consider upfront transplant for patients with a matched unrelated donor as well, and research is currently underway. Finally, the inherited marrow failure syndromes are a collection of unique diseases, some affecting isolated cell lines and others that result in multi-lineage failure. Malignant transformation to either MDS or leukemia is also a significant risk in this patient population. In many of these syndromes, marrow failure is only one of multiple issues these patients face. Therefore, transplant is only curative for the hematopoietic component of the syndrome. Here at Children's Colorado, we have a multidisciplinary team including transplant physicians, hematologists, and genetic counselors, in addition to our subspecialists such as ENT, dermatology, pulmonology, GI, and endocrinology, who all help care for this unique population both before and after transplantation. This multidisciplinary approach is critical for all patient care, as is access to new and developing treatments and approaches to transplantation. Our blood and marrow transplant and cellular therapeutics team is committed to advancing the field through research, and as such, are actively engaged in the development and implementation of multiple clinical trials relevant to the patients we treat. Please feel free to reach out to our team with any questions regarding transplantation for our non-malignant disease or for current trial availability.